Hi guys. We've spent the past couple of PowerPoint presentations talking about cell division and regulation of the cell division process, noting that on occasion when cells disregard the normal control signals that are placed upon them, regulating when they divide, we can on occasion develop into cancer. What I want to transition to now is how we detect when that happens and what we do when that happens. Detection of cancer often occurs through normal screening mechanisms. I want to talk about why we screen and a couple of the different methods that we use specifically to screen for breast cancer and colon cancer. So we've described how cells normally, specifically epithelial cells that would develop into a carcinoma, how those cells normally don't divide unless there are some sort of environmental signals that tell them that they should. If the epithelial sheet is intact, then there really is no room for a new cell to fit. So the normal epithelial sheet maintains its integrity without undergoing cell division. However, if a cell dies or a cell is injured, then normal division processes occur, mitosis specifically. And sometimes when mitosis occurs, mistakes are made, and if that occurs, those mistakes may lead to a cell growing in the absence of those appropriate signals, and in that case, the cells become hyperplastic, so they overgrow. Those hyperplastic cells just overgrow, and that in and of itself might be not particularly attractive, but there's nothing really wrong with that unless one of the overgrowing cells begins to look a little weird. And when that cell begins to look a little weird, we say that that cell is dysplastic. What we don't want is overgrowth of dysplastic cells, because when those dysplastic cells overgrow, that's when we may develop into cancer. Remember that dysplasia is sometimes considered a precancerous state. So what we would like to do is identify dysplastic tissues. When we're undergoing screening for cancer, we're actually looking for dysplasia. And the idea is that if we find dysplastic tissues, we can treat them before they ever develop into the neoplastic or malignant tissues that are cancer. So how do we screen for breast cancer? The process of breast cancer screening occurs through mammography. I have on the left an image of a machine that is used to do this mammography, and you can see by that little cartoon lady how this mammography process is supposed to go. There is a plate at the bottom that has film in it, and an x-ray will be taken of the breast, but in order to get a very clear image, the breast needs to be as thin as possible. So there is also a plate that is placed above the breast, and pressure is pushed down on this plate to squeeze the breast as thin as possible before the x-ray image is taken. The image on the right-hand side of your slide sort of shows what's supposed to happen, and in fact, ideally, that top plate would come down even further to make the breast even thinner than is shown in that diagram. Frankly, this is not the most comfortable procedure. So if and when you have a friend that is undergoing this procedure, you may want to throw that person a party. And if you do, you might want to make these little treats mammograms as a party favor. That's a joke. When should you have a mammogram? So unfortunately, there are a couple of governing bodies that tell us different things. One of those is the American Cancer Society, and their guidelines are shown in that box on the left. The American Cancer Society suggests that women at the age of 45 have their first mammogram, and from 45 to 54 have a mammogram every year. Once they turn 55, women are supposed to have mammograms every other year, but of course, the American Cancer Society leaves the door open, suggesting that women should have the opportunity to have an annual screening, an annual mammogram, if they would like to. In other words, these guidelines are used by insurance companies, and if a woman wants to have a mammogram every year, according to the American Cancer Society, insurance companies should pay for that. And then women should have an opportunity to have this annual screening up until the time that they are within 10 years of their expected lifespan. So for a woman, the expected lifespan is normally about 72 years old. So this would be having an annual mammogram until the age of 62. Although if you have a family history of a longer lifespan, you can extend that. So the American Cancer Society basically leaves it up to women to determine how frequently they want to have a mammogram. Of course, not more frequently than every year. The other governing body is the United States Preventative Services Task Force, and their guidelines are shown on the right. They're actually much more simple. They don't believe that there's any reason for a woman to have a mammogram before the age of 50. They believe that women should have that mammogram every other year until they are 74 years old, and at 74, mammography should stop, because realistically, if any cancer were to develop after the age of 74, frankly, it's more likely that you would succumb to something other than breast cancer before breast cancer would kill you. There are some limitations to mammography. Obviously, in the image I showed you, you might predict that there is some significant discomfort, and some women simply will not go for their annual or biannual mammograms because smashing your breast down hurts. It is also true that sometimes the images are unclear, and I will show you some images in just a second, such that you can get false negatives, meaning that the breast cancer, there is a tumor there, but it is not visible on the mammogram. That false negative range is anywhere from 4% to 34%. So if it's 34%, that means they're missing roughly a third of the tumors that might be there. The other limitation is that 75% of breast biopsies, so if somebody does see something that looks like a tumor on a mammogram, that is then explored a little further with a breast biopsy, so a biopsy of the potential cancerous tissue. And 75% of those biopsies are not cancer, so they're benign. And this 75% is a what we call a false positive, meaning that you get something that looks like a tumor that really isn't a tumor. There are some options to mammography, and one of those is sonography, or doing an ultrasound. The reason that this is not common is because it is more time and labor intensive, although certainly much more comfortable, but it does require that especially trained individual do the sonography, and then a radiologist read that sonogram in order to determine whether he or she sees something that might be suspicious. Another option is infrared thermal imaging, and thermal imaging depends upon the fact that cancer cells are much more metabolically active, meaning that they're growing much more quickly, so they're using nutrients and they're producing waste, and that metabolism produces heat, and therefore that heat might be detected through this thermal imaging. At this stage, thermal imaging is, while very sensitive, meaning you can see a lot of things, what you're seeing doesn't necessarily mean that you're seeing cancer. So you do get a lot of false positives with thermal imaging. Another option is a breast MRI. The major disadvantage of this procedure is that it's very expensive to do. A final option is something called breast tomosynthesis, and this is effectively a mammogram. So you do the same thing using a similar machine as the mammogram machine, but rather than taking an image in one direction, you actually take images in multiple different planes. So those different images then can be used to reconstruct a three-dimensional image of the breast. In the black box, you see a 2D mammogram. So this would be a side view of the breast tissue. So rather than squishing down on the breast tissue, they squish here. They squish together from the side, and they usually take two different images when they're doing mammograms. That would be a two-dimensional mammogram. But if you use this tomosynthesis to reconstruct a 3D image, you can see circled in yellow something that certainly is a tumor that seems hidden or obscured in the 2D mammogram. It is much more sensitive, and therefore you get fewer false positives and fewer false negatives, but it's also expensive because it requires a little bit different machinery, and not very many hospitals have this option. Another thing that I just want to throw out at you with respect to mammography is, bottom line, it's not particularly effective at stopping cancer. Well, the underlined sentence there says that despite the increase in number of breast cancers that are detected, screening mammography has only marginally reduced the rate at which women develop advanced cancer. In fact, the last sentence of this paragraph says that only a small effect on the rate of death from breast cancer has resulted from a massive mammography screening emphasis. And so the real question is, what good is all of this mammography screening doing? And you might suggest, and you might be right, but you might suggest that, well, gee, I'd rather screen a bunch of women and do all of this, these biopsies and whatnot, just to make sure that some of the breast cancers that people have don't advance, and some of those never develop into breast cancer. So while we're not having a large effect on the rate of death, even that small effect is significant enough to spend the time and effort and money to undergo mammography. But the average cost of treating cancer that is detected at various stages is shown in this box. So if we do treat somebody who presents with a stage 4 cancer, if we don't affect the rate of death of that individual, but we spend $135,000, is that investment worth it? And when I'm talking about spending money, by the way, I did mention that this screening is covered by insurance, but we all pay for insurance. So what I'm talking about really is the overall sort of societal cost of treating these cancers. And I'll let you sort of consider how we collectively in our society are using our limited resources and whether or not the use of those resources in screening for breast cancer is a valid one. What isn't controversial at all is screening for colon cancer. In fact, colon cancer screening has proven to be very effective at identifying dysplastic and early stage neoplastic tissues, and the treatment of those disorders has significantly reduced the incidence of colon cancer. The way that colon cancer is most often screened for is via something called a colonoscopy. The little cartoon on the left-hand side shows you that an individual undergoing a colonoscopy lies on his or her side, and then a tube with a camera called a scope. A tube with a camera is inserted in the rectum and is continually inserted to travel all along the length of the colon. The colon does bend, and as this tube, although it's a flexible tube, it's kind of like a very thin diameter garden hose, and so it doesn't bend super easily. So going around the bends of the colon can provide significant discomfort to the patient. So typically a patient undergoing a colonoscopy is sedated, and there is some there are some downsides to being sedated in that some individuals have negative reactions to that sedation. On the right-hand side, there are a couple of images that the camera on this tube have taken. In panel A, that is what a normal colon mucosa would look like. In panel B, we see a little bit of inflammation, so there's some redness and maybe a little bit of bleeding. This might be indicative of something, an inflammatory bowel disease like Crohn's disease or ulcerative colitis. In panel C, we see some little weird-looking pockets, and those pockets are diverticula. You may have heard of diverticulitis, and so there's a little bit of inflammation, but there are these little pockets into which fecal matter can find its way, and then it can create some infections. And this is very common, especially in this country, because it results from eating a high-fat, low vegetable diet. And finally, in panel D, we see a few polyps that might be those dysplastic polyps that would develop in somebody who was sort of on the continuum toward cancer. The United States Preventative Services Task Force, that same governing body that tells us how frequently we should have mammograms, also tells us how frequently we should have colonoscopies. I only put the Preventative Services Task Force recommendations up here because they do coincide with the American Cancer Society recommendations, so there aren't differences for colon cancer screening like there is in breast cancer screening. The Preventative Services Task Force recommends that individuals ages 50 to 75 have a colonoscopy, a sigmoidoscopy, which is using a shorter tube and just going in the first arm, if you will, of the colon rather than bending around. or a fecal blood test. So that is simply taking some stool and looking for blood. If there's blood, it means that that's not good, but it doesn't necessarily mean that it's cancer. So it could be any of those other things that were shown in disorders that were shown in the previous slide that might produce blood, but that might make somebody getting a positive result on a occult blood screen might make them upset and concerned for no reason because it isn't cancer. So, but regardless, the Preventative Services Task Force says that any of those screening mechanisms is good. That's why it's in this sort of green bar of the table. And this should begin at age 50 and continue until age 75. In the yellow bar below that, the Preventative Services Task Force doesn't believe that anybody over age 75 needs to have a colonoscopy. However, there may be some individuals, people who have had a history of colon cancer in their family, or perhaps people who have an inflammatory bowel condition. Those individuals, it's okay to undergo colonoscopy until the age of 85. The Preventative Services Task Force does not believe anybody over 85 needs to have colorectal cancer screening, because for the same reasons that mammography stops when a woman reaches a certain age, it's thought that once you're 85 years of age, the likelihood of you dying from colon cancer, even if you develop it at that age, are probably pretty slim. And then finally, there are some alternatives that I'll show you on the next slide to colonoscopy. And one of those is fecal DNA testing. And what that is you are looking for specific altered DNA sequences whose alteration are very common in colon cancer. And you do that because the idea is that you are shedding off some of your normal colon epithelia, but you're also shedding off some of your abnormal, potentially cancerous epithelial cells. And if you can screen for those cancerous cells in the stool, then that's certainly easy. You may have heard commercials for this test. It's called Cologuard, and Cologuard has not yet been approved by the FDA as a suitable screening mechanism for colon cancer, and that is because in a clinical study there were a significant number of both false positives and false negatives, and so that's why in this table it's identified as white, because bottom line, the jury is still out on whether or not this is a suitable way to screen for colon cancer. There are limitations. As I said, there's significant discomfort. Some people won't do it, and that's not during the procedure itself, but as you might imagine, you should not have any stool in your colon or any partially digested food in your colon as you're undergoing this screening procedure. So there are some pretty significant laxatives that people must take for a couple of days prior to undergoing this procedure. People are not allowed to eat for at least a day, so it is not particularly pleasant, and so some people don't undergo this screening for that reason. There are risk of complications, so some people, as I said, have a negative response to the anesthesia, and other individuals might that relatively inflexible tube might perforate somebody's colon, especially if somebody has an inflammatory condition where their colon is not particularly healthy. Because the tube goes around the bends, it can induce bleeding by tearing or shearing the mucosa, the physician has to be pretty good at looking very closely for all of these polyps, and it's not realistic to assume that a physician would be able to see all of them during a single procedure. So here are some options. So as I said, there are some fecal immunochemical tests. So these are tests where there are specific metabolic products that can be tested for in the stool. It's possible to do an enema that you would have an x-ray after, and that can show some odd folds or maybe some diverticula. It may show some very large polyps, but not certainly small ones. You can have a fecal occult blood test. So this is again looking for blood in the stool, fecal DNA, that Cologuard. It's possible to have a CT colonoscopy. This is using a CAT scan. Commuted tomography is what CT stands for, and it actually is it's a very good way to screen for colon cancer, but it's also very expensive, so it's not typically done. Sigmoidoscopy is looking at that first arm, as I said, of the colon. And there is also something that has recently come on the market that's called a pill cam. You swallow this fairly large pill, but it is a camera, and it will record digitally the pathway through your gastrointestinal tract, and that can be sent to your physician's computer, and so your physician can look at your entire digestive tract over the course of the 3-ish days this pill cam takes to travel through your GI tract, and then you just simply pass it through the stool, and no, you don't recover it. So these are various mechanisms by which colon cancer can be screened for. Only the fecal occult blood tests, colonoscopy, and sigmoidoscopy are approved by both the American Cancer Society and the Preventative Services Task Force as proper mechanisms of colon cancer screening. We'll transition in the next PowerPoint to talking about treatment of cancers should a cancer be identified via one of these screening mechanisms.